mandible to the maxilla. So you're looking again for wipeout of the, you can see right here, PIP has rubbed off at that hamular notch area, and that can be opened up a little bit, and that can sometimes solve the entire problem. So if the maxillary denture loosens when the patient opens widely, is it the maximum loosens when speaking? Mandibular lacks retention on insertion, or it loosens at different times of day. These are all different complaints that have different causes, and the complaint will clue you in as to what the cause is. Frenum ulceration will clue you in as to what the cause is. Obviously, you need to deepen the frenal notch. So if it lacks retention on insertion, then you probably don't have posterior palatal seal. That is pretty easy to test by putting a little pressure on the incisors and canines to support the denture. If the denture tips when you do that, then you know that the seal isn't very good. The denture may be too short, the denture may be too long, maybe inadequate depth of the seal, or that hamular notch is an issue. Okay, so if it's too short and ends on non-displaceable tissue, you can, again, mark it with an indelible pencil, have them speak to see where that vibrating line is, and then see if you need to extend the denture, which is something you can do without making a new denture. So this slide shows where the ideal posterior palatal seal should be. Remember, you don't want it on non-displaceable tissue. So you're checking for looseness on excursions with the fingers on the canines again. Gently hold the denture in place there. Have them do excursion, see where the forces of tipping are experienced. Maybe a balancing issue again, done by occlusal adjustment. If you don't have a good post-dam, then you want to pull upward on the denture on the canines and see if it drops down. Then you want to start adding, like you see in this slide, with some wax or compound or bite registration material. You can add to the denture, see if that improves it. If it does, then you can make that change more permanent with acrylic. We talked before about the alveolus resorbing and causing a rocking on the center of the palate. And you can see this fulcrums on that palate that didn't change. And that's a pretty good hint that that's what's going on. You want to test that with PIP and reline that rather than grinding through the center of the denture, particularly if the center of the denture is thin. Okay, if you don't want the periphery to terminate on bony structures, okay, because that does not give you a seal. Okay, it prevents the denture from sinking in a little bit and sealing. And so you will usually see some discomfort as associated with the no seal, and you do get eventual resorption as well as that is. So if the flange fits on the touches on the zygoma, which is not giving, it will not seal well. Those people that have that midline soft palate fissure can be difficult because you can have some air leaking underneath there. It's hard to get the seal if that fissure continues all the way to the end of the denture. If you fill it in, sometimes you have a sharp edge of acrylic, which is like a knife to the palate, and that doesn't work. So look and see if you can figure out what's the problem first. Sometimes the solution there is going to be a soft reline. If the maxillary denture loosens when speaking, there's a number of different possible causes for that. The inadequate post-palatal seal, which we talked about already. Interference with the coronoid process, we also talked about. We're using the PIP on the outside of the denture to see if the coronoid process rubs off the PIP. If the posterior border is too short or long, that's going to make a difference. And then a short labial flange, or excessive notch for the labial frenum. All of those things can cause those retention problems. It's loosening when speaking. When the mandibular lingual flange is too thick, sometimes that can cause a soreness on the opposite side of the denture because of the tongue crowding, causing the denture to tip. And when the denture tips, it's the opposite side that careens into the tissue and can cause the soreness. So you're looking at that. You're looking at tongue movement, whether the denture is moving when the tongue moves, which direction it's moving, and that can account for some of that tipping. And so rather than grinding the contralateral side's flange, you may want to thin the flange on the side that is causing the tipping. When the mandibular lacks retention on insertion, typically it's caused by some of the things listed on the slide. The buccal flange is underextended, the labial flange underextended, or an overextension of lingual borders. So the tongue displaces the denture left or right. That was the previous slide that showed that. And always check your notches for frenums and make sure, usually they need to be deepened more than they need to be widened. So you'll take a look at that and try to keep it as narrow as possible. If you make it too wide, you can have a loss of seal. Okay, if it's sometimes okay and sometimes not okay, the complaint is at different times of day, that's usually indicative of the tissues either compressing or the salivary secretions varying from time to time during the day. And it may not be something you can solve by changing a denture or relining a denture. So again, this goes back to the principle, figure out what the problem is before you start making changes. Perpetually loose maxillary denture, when there are occlusal causes, because we always talked about some of the other causes, you can have heavy anterior interferences. So you take a look at, again, the occlusion on that. The tuberosity can grow into the space, and then the space develops under the midline. So this is a process that occurs where the tuberosity, first the denture tips forward because of forces on the anterior. Then the back of the denture drops down. Then that happens chronically. The tuberosity starts to grow into that space, and now you can't, let's go back. Now you have this space on the palatal area after the tuberosity has grown into the space and no seal. So this is the kind of situation where the mouth has changed considerably. As a result, the denture fits completely differently. May have been preventable with the right occlusion, but you can consider this as a possibility. It seems a little miraculous. How come the tuberosity is so much bigger? Patients wearing the denture all the time, and this is the explanation for that. Another error that can occur is when the incisors are placed too far labially on the lower, then the lip will push the denture up, particularly if the alveolus has an inclined residual ridge, and so everything can slide easily up because there's no resistance. People report tilting or jiggling can be sometimes because the contacts are not centered over the ridge. Everybody understands how to set teeth. Remember that if you're troubleshooting a denture, you're looking to see if the previous person set the teeth right, or if because of the time that the dentures existed and the change in wear of the denture, change in resorption on the tissues doesn't meet the same way, the contacts aren't centered over the ridge, that can be something that's causing the tilting or jiggling. With respect to phonetic problems, patients report sudden lisping, too much overjet. That can sometimes occur when dentures are sliding. Some of these other things are a little bit more built into the denture, so there would be a problem from day one, like the triangular spaces between the embrasures of the maxillary and mandibular teeth are allowing too much air to escape. Okay, that's what that sound of a lisp is escaping air when you put your tongue on the anterior palatal area to create an air seal when you try to say certain sounds. You can also have a contour that's too constricted palatally for the denture. That will prevent the tongue from getting that seal or insufficient tongue space. All of those things. Lisping is typically